that acute encephalitis syndrome is a common neurological emergency with diverse etiologies and outcomes. Acute encephalitis syndrome is associated with considerable acute complications, new onset of the seizures, and these seizures is not the febrile seizures. If any condition fulfills this criteria, we coin as the acute encephalitis syndrome. Herpes simplex encephalitis is the most common cause of sporadic encephalitis, and therefore I think very important for any clinician to know. And therefore it is very important for the clinician to recognize it early and initiate the prompt appropriate treatment which will result in a better outcome.
Hello, thank you for tuning in. If you want to come back to this video later, just tap on the like button. It will save it to your liked videos so it's easier to find. And don't forget to hit on the bell icon to get notified whenever we drop new content. Stay curious, keep learning, and see you on the inside.
Welcome to this our evening program. Today I am going to discuss with you very important topic, acute encephalitis syndrome. Friends, you will agree with me that acute encephalitis syndrome is a common neurological emergency with diverse etiologies and outcomes. Acute encephalitis syndrome is associated with considerable acute complications and frequently mandating ICU care management and a high burden of long-term morbidities affecting the quality of life. And therefore, it is very important for the clinician to recognize it early and initiate the prompt appropriate treatment which will result in a better outcome. Now the first question comes, how we define this acute encephalitis syndrome? Recently, WHO has given the very clear-cut definition that acute encephalitis syndrome is defined as a person of any age at any type of year with acute onset of fever and a change in the mental status, which may be in the form of the confusion, disorientation, inability to talk, or may result in coma. Any form of mental change in the mental status, which should be at least more than 24 hours duration, and or maybe new onset of the seizures. And these seizures is not the febrile seizures. If any condition fulfills this criteria, we coin as the acute encephalitis syndrome. Then the next question comes, quite, I would say, similar word, is the encephalopathy. What we mean by the encephalopathy? Please remember that encephalopathy is a broader term which is characterized by diffuse cerebral dysfunction and which may be again due to various toxins or inflammation, and that inflammation may be infective or non-infective origin. Friends, please remember that the encephalopathy includes hepatic encephalopathy, uremic encephalopathy, Reye syndrome, seizure encephalopathy, even viral encephalitis, autoimmune encephalitis, hypoxic ischemic encephalopathy, acute bacterial meningitis, tuberculous meningitis, and so on. That means any of these conditions, generally we say encephalopathy. Now the next question comes, what are the common causes of acute encephalitis syndrome? Most commonly we come across the viral etiological agent. Maybe in the form of the Japanese encephalitis, in the form of the epidemic, very well known in certain parts of our country, particularly eastern part, Bihar, West Bengal, Assam, and even southern some parts in the form of the Karnataka, Tamil Nadu. These areas are having the problem of Japanese encephalitis. Herpes simplex encephalitis is the most common cause of sporadic encephalitis, and therefore I think very important for any clinician to know. Occasionally even the other viral infections may present as a complication in the form of the encephalitis like dengue, chikungunya, Chandipura virus, Nipah virus, varicella, measles, Epstein virus, mumps even, HIV, COVID, and even the rabies. Then the next group comes as the bacteria. Which bacteria is known to present with this encephalitis syndrome? In the form of the acute bacterial meningitis, tuberculous meningitis, Shigella, even brucellosis is known to present with the CNS involvement, leptospirosis, meningococcal allophosno, and recently even some parts of our country, mycoplasma has come up, and mycoplasma can involve any system of the body. Well known, even it can cause the encephalitis due to the mycoplasma. Next, various groups like parasitological causes, most common is cerebral malaria, rickettsial disorder, again very common in certain parts of our country, particularly sub-Himalayan area, again West Bengal, some parts of Karnataka, Tamil Nadu, particularly scrub typhus fever. Of course, all of us are aware that autoimmune encephalitis, ADM, and NMDR encephalitis are also known to present in the form of acute encephalitis syndrome. Even there are certain important clues which we should be aware in the history, particularly like demography, outbreaks, travel, even age of the patient. Very important, location from where the patient is coming. As I said, some of the parts are endemic for the malaria. Some of the states, as I already mentioned, are having the Japanese encephalitis. Even the rickettsia is reported from some particularly forest areas. And therefore, history of travel to these parts is very, very important. Even contact with the animal or animal products. We know that dogs is known to cause the rabies. Even the cow's milk or even the contacts with these animals can cause the brucellosis, leptospirosis, particularly with the urine contact of the mice. Similarly, rabies, exposure to the mosquitoes, all of us know, even tick bites responsible for rickettsia. Immunocompromised individuals can develop any sort of problem. Family history is very important, and even the previous history of headache, vomiting, or seizures, history of chronic hepatic or renal disease, they can result in the hepatic encephalopathy or uremic encephalopathy. Even Glasgow Coma scale is very important clue on the examination. That will give the objective status of the level of consciousness of the child. Look for the skin rash. All of us know in this season, particularly the diffuse measly rash seen in a case of dengue fever. Even chikungunya, particularly the rashes in the infants, which may be blackish in color. Measles, all of us are aware. Similarly, vesicular rashes in a case of varicella, hemorrhagic rashes in a case of meningococcal meningitis, scrub typhus, petechial rash is known in a various viral like arboviral, meningococcus, scrub typhus. Please remember, a scar is very important clinical clue for the rickettsial disease. And therefore, if you are suspecting rickettsial disease, search for the unusual sites for the scar, which may be with ear, which may be the axilla or even the genital areas. So once you are suspecting, try to get it. And if you get the scar, it is considered as pathognomonic sign, important clue for the diagnosis of rickettsia. Similarly, lymphadenopathy, which is very characteristic of some conditions like Epstein-Barr virus, tuberculosis, HIV, mumps, all of us know will present with the peritonitis, jaundice, maybe in a case of leptospirosis, dengue fever with the involvement of liver or even the hepatic failure. Severe pallor may be in a case of malaria. Hepatosplenomegaly is known in a case of malaria, scrub typhus, and tuberculosis. Please look for the signs of raised internal pressure in the brain herniation, which may be the life-threatening conditions which we should keep in mind. Even signs of meningeal irritation should be checked, which may be in a case of acute bacterial meningitis, tuberculous meningitis, and even some other conditions. Investigations point of view, go for the CBC. That will give you the idea regarding the drop of hemoglobin in a case of malaria, high count in bacterial infections, thrombocytopenia in various viral infections and rickettsial fever. Peripheral smear examination is very important for malarial parasites. Of course, for particularly metabolic derangement, check for the sugar, SGPT for hepatic involvement, creatinine for renal condition, and electrolytes, very, very important. Any case of this encephalitis syndrome, CSF examination is very important, and it cannot be replaced by any sophisticated investigation like CT or MRI. Of course, contrast in a CT and MRI is very important, particularly the conditions like tuberculosis or tuberculous meningitis, which may show meningitis, tuberculomas. MRI is very important, particularly for the autoimmune encephalitis. EEG is particularly characterizes some of the conditions like SSP or even the herpes simplex encephalitis. So EEG is also important, I will say, investigation in this type of the situation. Nowadays, we should know that we have the molecular diagnostic facility, or sometimes when we use the serological test, even in the CSF, like investigation of CSF, HSV, PCR, scrub typhus, even the serological test we do. But please keep in mind that ELISA is more reliable rather than any other simple technology like CAR test. Friends, I want to share with you the very simple table that how the very common differential diagnosis can be differentiated from the simple points, simple investigations. Usually the viral CBC may be normal or maybe the low count. Sugar is usually normal. Hepatic enzymes may be elevated. Chest oxygen is usually normal. And contrast MRI may be the very characteristic. Mycoplasma, as I was talking, may go for sudden drop of hemoglobin, sugar normal, SGPT may be elevated with the involvement of liver, some infiltrates or pneumonias you may get in chest x-rays, but usually MRI may be normal also. Similarly, for acute demyelinating meningoencephalitis, probably the blood test in the form of the CBC, sugar, SGPT may be normal, chest x-ray may be normal, but very important CSF examination and contrast MRI. Malaria is very characteristic drop of hemoglobin, sometimes thrombocytopenia. Sugar may be low, hypoglycemia is common, SGPT may be elevated, X-ray may be normal, and usually MRI, cerebral, I will say radio imaging may be normal except in cerebral malaria may show some infarct or the edema. Tuberculosis point of view, blood test may not be much contributing. Very important is CSF examination, chest X-ray, and radio imaging for the brain. Scrub typhus, very characteristic, we get the thrombocytopenia, sugar may be normal or low, SGPT elevated, X-ray is normal, and radio imaging for the brain, particularly the contrast MRI, may show the changes of vasculitis. So I think from simple investigations, you can get the very important clue. As I was talking, CSF, usually in viral encephalitis, you may get some abnormality. Cells may be some hundreds or so. And particularly the RBCs in a case of herpes simplex encephalitis, because it causes the necrotizing encephalitis. And therefore, to get the RBC is very important clue for HSV. Sugar may be normal, but yes, mumps may show the abnormality, and that is the hypoglycemia. Protein usually elevated, but mild to moderate. In mycoplasma, CSF is usually normal, maybe some cellular reaction, but otherwise not contributing much. ADM, I think more contributing is the MRI rather than the CSF. And cerebral malaria, again, may not be much contributing the CSF examination. But to rule out the other conditions, we have to do. Tuberculosis, meningitis, yes, CSF is very, very important. And therefore, there may be cells may be some hundreds, protein is raised, and sugar is usually normal or low. In scrub typhus, some cellular reaction and mild protein raise, you may get it. So these are the very characteristic in the CSF differentiating various close conditions. If I share with you the scrub typhus in our country, I think very interesting the data are available. In CMC below, they studied 48 cases. They got it. And most of them, almost 50% was having the encephalopathy. Rash was very common. Thrombocytopenia was common. And splenomegaly in almost 50%. At the same time, 30 cases they studied at Institute of Child Health, Calcutta. They got the encephalopathy in almost similar, around 40 to 45%. Rashes, 60%. Splenomegaly somehow was common with them, but thrombocytopenia again around 60-65%. And multi-center ICU studies with the 83 patients, where they got the encephalopathy, 25, but rash was very common. I think all the three studies, rash was very common. And even the thrombocytopenia was also commonly observed. So I think this is very important data, which has been recently published in Indian Pediatrics in 2018, and worth, I will say, to observe, which will give you the idea that how common rickettsia presents at different parts of our country. Friends, one more important clue I would like to share with you. Where is the predilection for the parts of CNS in various viral infections? And therefore ask a radiologist, in a case of viral encephalitis, that which part of the CNS is affected. Because it becomes very important clue for me for the diagnosis. In a case of herpes simplex encephalitis, involvement of temporal lobes is very, very common. While involvement of basal ganglia is favoring Japanese encephalitis. We know that the varicella can cause the cereballitis, and therefore cereballitis or the white matter involvement of cerebellum favors the post-varicella cerebellum infection. We know that polio is a disease of anterior horn cells of spinal cord and may involve the motor part of the midbrain. Mumps is a very characteristic involve the ependymal and the choroid plexus cells. And friends, cytomegalovirus, if I remind you, is known to involve these particularly the walls of the ventricles. And therefore, periventricular calcification, if you get it, in a given scenario, probably that helps a lot to come to the conclusion for the cytomegaloviral infection. Epstein-Barr virus, again, is known to cause the vasculitis. And rabies, Emmons Hall involvement is very common. So I think this is the thing which I wanted to share with you, that ask your friend, the radiologist or the pediatric neurologist, that which part of the CNS is specifically affected. Because that becomes very important clue for me as a clinician to clinch the diagnosis. I want to share with you some of the pictures of MRI. As I was talking, you can see the Japanese encephalitis involvement of basal ganglia. ADM, if you see the diffuse, particularly the demyelination, particularly with this, it is a generalized demyelination. And herpes simplex viral encephalitis, in that condition, particularly involvement of temporal lobe, is become the very important clue for me to clinch the diagnosis. So these are the points which we can remember in our daily practice. Friends, I think this very simple algorithm is prepared by the WHO recommendation for management of acute encephalitis syndrome, which is very important for the clinician to keep in mind. As per the definition, already we discussed that at any time, any age of person, presence with the fever, seizures, and altered sensorium, I think it's sufficient to coin syndromic condition, that is acute encephalitis syndrome. And having this situation when the patient comes, as I said, it is an emergency. So my first aim is to resuscitate the patient, go for the supportive care in the form of if requires, when the correction of hypoglycemia, correction of fluid, even the correction of hypoxemia by oxygen. If seizures, I have to control first with the proper anticonvulsants. In the form of when the older the child, I may start with the phenytoin or phosphenytoin with the loading dose of 20 milligram, required again 10 doses, 10 milligram per kg can be repeated, maximum 40 milligram per kg. I would like to remind you, with the phenytoin, please monitor this particular the cardiac monitoring. Reason, it is known to cause this cardiac arrhythmia. Similarly, if it is not controlled, you can go for levetiracetam, you can go for even the sodium valproate. If it requires, even we have to go for midazolam, and like that, we'll have to go till it is controlled. If there is a raised intracranial pressure and signs of cerebral edema, probably immediately you can go for the mannitol, 0.25 to 0.5 gram per kg. They say that maximum for a day or two. And good results are there with the 3% normal saline, 3% saline. Of course, even other drugs can be used. So this is very, very important. Probably after stabilizing the patient, detailed clinical examination is very important, which already we discussed, try to get an important clue. Of course, repeated routine investigation should be sent in the form of the CBC, malarial parasites, peripheral examination, blood sugar, SGPT, electrolytes, creatinine, chest X-ray. And if the patient's condition allows, we should go for the CSF examination. If patient's condition is critical, not allowing due to some cardiorespiratory problem, we have to wait for some time. And once the patient's condition improves, you can plan for the lumbar puncture. Meanwhile, empirically, we have to heat very hard. And therefore, you can start the multiple drugs. till you get the various results of your investigations. And particularly, you can start the IV acyclovir, ceftriaxone. Even suppose the patient is from the endemic area for malaria, artesunate may be required. Similarly, as I talk, patient is coming from the area where this rickettsia is common, doxycycline. Doxycycline at present, the people say, WHO is recommending that if you have the possibility of the rickettsia, don't wait for confirmation. Empirically, you should start the doxycycline and your results are good. Meanwhile, you can plan for the radio imaging, MRI brain, EG, and even these other investigations. So I think this is very good algorithm. Meanwhile, as I said, suppose from the investigations, if you get some results and definitely diagnosis, suppose if you got the cerebral malaria, stop the acyclovir and ceftriaxone. If you confirm the bacterial meningitis, stop, I will say, anti-malarial and other drugs and continue the antibiotics to treat the acute bacterial meningitis. So I think very important. And continue the specific therapy. By chance, if it is not confirmed, you don't have the clear answer. The people say that you cannot differentiate particularly the herpes simplex encephalitis, and therefore continue the acyclovir. And even the artesunate, you may omit if you have got some other clinical result. So I think this is very important clue for the clinician to decide in daily practice. Friends, some of the points I want to share with you investigations, it was regarding CSF PCR for the herpes simplex. Please remember, this is the very important investigations for diagnosis of HSV encephalitis. It is very highly sensitive, almost 94 to 98%. And specific, I can say almost 100%. So I think CSF PCR for herpes simplex encephalitis is very important investigation. Suppose if it is negative, because if it is done 22 hours of illness, repeat after 24 hours. And it is said that suppose both the CSF PCR are negative, almost herpes simplex encephalitis is excluded, think something else. Another point, please remember that the CSF PCR may remain positive for almost a week after starting the drug. So from that, you don't decide whether the patient is responding or not. This is very important point. Similarly, MRI, as already I shared with you, temporal lobe involvement, it is said as the very important point to consider this herpes simplex encephalitis. Of course, it can be with a generalized involvement also. Friends, in MRI, 90% will show some changes. Therefore, again, absolutely normal MRI probably not somehow acceptable for the herpes HSV encephalitis. Of course, maybe normal if it is done early. And as I talked already, the temporal lobe abnormality is highly suggestive. Of course, other changes you may get in cingulate gyrus, infralateral frontal lobe, may show even the other abnormalities. Limbic system abnormality is very characteristic for the HSV encephalitis. Even as I was talking, EEG is also very characteristic. They say that 84% sensitive. Of course, changes may not be the very specific for HSV. But spikes and slow and periodic sharp waves in the temporal lobe and diffuse slowing, these EEG changes may suggest HSV encephalitis. Friends, early treatment we have outlined that go for the airway breathing circulation, resuscitation. That is, I will say, the prime or very important exercise which should be performed immediately. Supportive care is very important, particularly from the hypoxemia, hypoglycemia, dehydration, convulsion, control. All the things are very, very important. Antibiotics, IV ceftriaxone, endemic area, attenuative care. If you have the possibility of even the rickettsia, you can go for doxycycline. Herpes simplex, if you consider IV acyclovir is very important, 10 mg per kg, 8 hourly for 3 weeks. Please remember, CNS involvement of the herpes simplex, only IV route and for 3 weeks. For probably other sites of infection, that is the oral cavity or even the skin encephalitis or even the genital, you can go for 10 days to 2 weeks, but CNS 3 weeks. Very important point, please don't start empirical steroids. It's not helping, not rewarding. On the contrary, you may invite the trouble. So I think these are the very important principles of management of any case of acute encephalitis syndrome. Again, if you have got the definitive diagnosis, which may not be very clear in every case, but here the early treatment is very crucial. Treatment should not be delayed for confirmation of your diagnosis. Treatment decisions should be made on clinical diagnosis. Later on, you can go for the, I will say, de-escalation or modification. And please, you should be well aware of the epidemiological data going on surrounding to you. And confirmatory lab tests are most of the times retrospective, but that also we should perform, particularly to know the epidemics in your area. These are the things which I wanted to share with you, and thank you very much. I hope that in a very small, simple presentation, I have conveyed the very important, I will say, messages quite useful in our daily practice. Thank you, friends. Thank you very much.
Thank you so much, sir, for sharing your valuable knowledge with us. It was indeed a very
Well, can you
interesting
just
session.
stop sharing?
Yes, I can do that. Sir, I will be reading out the questions, and the questions will also be available. You will also be able to see the questions in the screen below.
Sure.
Dr. Madhav has asked, is doxycycline helpful? Why and how?
Doxycycline is useful only for rickettsia. And rickettsia is a disease by these particular organisms where doxycycline is most effective. And therefore, for rickettsia, irrespective of age, usually doxycycline we don't recommend in younger children less than 8 years. But if you suspect rickettsia, you can give it. And don't even wait for the confirmation by the investigations.
Okay. Coming to the next question, it is asked by Dr. Ravindra. What is etiology of mental retardation followed by episode of TB meningitis in children?
Any CNS insult will result in a damage to the brain, various parts. And that is, suppose in a case of tuberculous meningitis, if we take, it will cause the most commonly tuberculous vasculitis, and then some parts of the brain will be ischemic, and therefore damage to the tissues of the brain, cells, which may not be reversible, and therefore function is lost. And therefore it will result in mental retardation. Similarly, you know that it is well known with the hypoxic ischemic encephalopathy, that is birth asphyxia. In birth asphyxia also what happens that the baby is not getting the sufficient oxygen, and that hypoxemia will cause the damage to the brain. And that again ischemia will cause the permanent damage to the cerebral cells, and which results later on in the damage or sequelae, and most important sequelae, the mental retardation, which can be with the various reasons. Even any encephalitis can cause it, tuberculous meningitis can cause it, acute bacterial meningitis can cause it, stroke can cause it, or even the hypoxic ischemic encephalopathy can cause it.
Coming to the next question, it is asked by Dr. Sridhar. Will acute encephalitis syndrome caused by CMV cause calcifications?
Usually CMV will not cause the acute encephalitis. It's a chronic condition, chronic viral infection. But of course, there will be the CNS involvement, very common. And when we are searching for the various important clues which I was discussing, if you go for this radio imaging of the brain, if you get the calcification in the periventricular area, because subependymal layers, it is like the affinity for these viruses. They are getting deposited, and with the damage, it results in the calcification. Similarly, if you get these scattered calcifications in the brain in a congenital infection, that is the important clue for the toxoplasmosis. So therefore, in which part you are getting the calcification will give the important clue for this viral infection, either the cytomegalo or toxoplasmosis.
Okay, next question is asked by Dr. Farooq. Indications of steroid therapy in acute encephalitis syndrome.
As I said, that avoid the steroids unless there is one definite indication. What are the indications? Tuberculous meningitis. Yes, it is indicated that you can start this dexamethasone 0.6 milligram per kg per day, almost for 4 weeks. Later on, taper in the 4 weeks and total complete in about 8 weeks or so. If you want to go for oral, if the child is able to take orally, we can go for prednisolone, initially 2 milligram per kg, then decrease the 1 milligram per kg and 8 weeks. But any encephalitis should not be said. Yes, there are certain indications. Suppose if you get the autoimmune encephalitis, there may be even the indications for intravenous immunoglobulins. Certain conditions, suppose NMDR encephalitis, then steroids are indicated. But point is, unless you have confirmed that the strong indication is there, just we should not start the steroids. That's the important message.
Okay, sir. Next question has been asked by Dr. Jayashree. Chikungunya encephalitis. Can you guide?
Chikungunya encephalitis, I will say not so common, but yes, it has been reported. Chikungunya even is known to go for the systemic infection. Usually it will present with the high-grade fever, skin rashes, joint pain, and other manifestations. But of course, in young children or even immunocompromised status of the person, even adults, then they may go for the systemic viremia, and it can cause even the encephalitis also. It has been reported. No.
Coming to the last question of the night, sir. Is HSV encephalitis in patient need hospitalization for 21 days for acyclovir IV administration? It has been asked
Of
by
course, certainly, because as I said, it requires only IV. 21 days. Both the things are very strong. There is no compromise. And therefore, the patient should stay in the hospital. I think here somebody has asked the question. Let me elaborate. Recently, I am observing the practice of keeping the vigo in situ, continuing the intravenous therapy, either even the antibiotic like ceftriaxone in a case of enteric fever, and allowing the patient to go at home. I think this is not a safe practice. I know this practice is very common at many places. But I have seen even the complication of bacterial endocarditis in these patients. I have seen the complications following this, even the extravasation, cellulitis, even gangrene. And therefore, I think it is not the safe method of treating the patient as an outdoor for the intravenous drug therapy and not for this acyclovir. Because on the contrary, acyclovir is known to create the problems. So certainly, certain conditions where only intravenous antibiotics, no oral, no intramuscular. One of them is a CNS or herpes simplex encephalitis. Another, if I say acute bacterial meningitis, only IV route. Neonatal meningitis, intravenous antibiotic for 3 weeks, only IV, no any other route. Bacterial endocarditis, to be treated for 4 to 6 weeks, only IV antibiotics, no oral, no intramuscular. So I think these are the certain conditions which we have to keep in mind, where only IV route and best ways to treat with the indoor patient, not as outdoor. Thank you very much. I think it was a very good question.
Thank you so much, sir, for taking out your time tonight. It was a really informative session.
Thank you. I hope that we could solve the problem of the presentation, some technical issues. And I think that our whole presentation, without any interruption, we could complete. And I hope that it should be quite useful to all the practitioners in their daily practice. Thank you very much for inviting me and giving this opportunity. And good night to all of you.
Good night, sir. Thank you.